So in our emergency departments, we have better access to information that just confirms what we've been able to see anecdotally, that we are the highest users of opioids in the world, and people often come in asking for more opioids. We have policies in most emergency departments that refills of opioids that are being used chronically will not be given, that opioids that are prescribed will be given in small amounts. This is a tricky issue because it has to be balanced with recognizing that people have chronic pain, that people are genuinely suffering, that you don't want to have people feel like they've been labeled as users or diverters of medication when they come to the emergency department seeking help. And so you have to balance that role with the recognition that we are not in a position to prescribe opioids in large amounts or on a chronic basis from the emergency department. And it's sometimes a difficult task, particularly when we see people who are in genuine pain or in genuine need of treatment of their pain. There is a tremendous push to use alternative modalities of treatment for pain and to use other tools in our toolbox. There is increased monitoring in emergency departments of opioid prescriptions. For example, at London Health Sciences Centre, each emergency physician gets an electronic scorecard that tells them what % of their patients received an opioid prescription and compares it to our peers and the other emergency physicians to tell them how many opioid prescriptions they are prescribing compared to their peers. So that's a nice tool to allow one to reflect, am I prescribing more opioids than my colleague? And there's work being done to try and expand that type of monitoring across our region, which I think is a valuable feedback tool.